Hello, hello, can you hear me?
Yeah, I can hear you. Can you hear me?
Yes, okay, yes. Audible, sir.
Okay, thank you.
1 minute, sir.
Good evening.
Good evening, sir.
Good evening, Albin.
Is everybody in? Fala.
Good evening, Paula.
Fala, can you hear? Fala, hello. Good evening. Okay. Dr. Albin, can you hear? Okay, I just muted. Okay. Everybody can see the screen, right?
Yeah, we can see the screen.
Okay.
Good evening, Dr. Parak.
Can you all see me? Okay, 1 minute. Mm. I think I didn't get anyone to host the meeting, sir. The one who was supposed to host the meeting had duty today.
Or you can.
I think Emmanuel sir will join now.
Okay. Good evening, Dr. Amrut.
Good evening.
Can't see fella. He was there a while ago, but he's can't be seen now.
I can see, sir. Fala.
His video is off. His audio is off. I think. So,
I think he has muted, I think.
yeah, muted message.
Now, how many people have joined? 9 people have joined. Yeah. Can... Okay. Emmanuel sir has joined.
Yeah, okay. Yeah, it is
You can
working.
start.
Sorry.
Emmanuel sir has joined. Okay,
Ah,
he
yes,
has
yes.
joined. Yeah.
Hi, fella.
Hi,
Can you hear?
hi, yeah. I'm hearing.
Yeah. Hi, Dr. Emmanuel.
He is on the way to home, I think. Cycling. Amrit, can you call John Jacob sir and see how he is available or not? Because I am doing the host work and
Can you start?
I think we'll start because it's yeah.
so I'm presenting a case. 27-year-old Meena. She's from a tribal community. After giving birth to her first child, she was found to be increasingly agitated and was found to be uncaring for the baby on the 5th day postpartum. She had an uneventful antenatal period. Her brother had a history of schizophrenia. Anything you want to think about in this scenario? What all things are going through your mind?
Postpartum blues. Postpartum blues will be the choice for this lady.
Why do you say it's postpartum blues rather than something else more serious?
I mean, in the history, they didn't mention about clearly whether it is a really symptom of a psychosis or a symptom of neurosis, sir. And here, it's also the duration is a very shorter duration to keep like postpartum psychosis. Usually, the diagnosis usually after 6 weeks or like that, sir. It is in early terms. Within 1 week, no, better to consider it as a postpartum blues. So.
Yeah, I agree that that's a good point, that postpartum blues usually starts around the 3rd or 4th day. But generally, that's the symptoms of postpartum blues are feeling of questioning her ability to care for the baby, being irritable, feeling tired, the mood fluctuating from being anxious to um, feeling slightly somewhat depressed. But it doesn't usually go to the extent of being unable to care for the baby at all. Generally, if it's something serious like mother completely neglecting the baby or being unable to breastfeed or do anything any other alternative feeding, that tends to be something more serious. You're right about postpartum depression. Generally tends to start a little later, but postpartum psychosis can start very early as well.
Yes, sir. Thank you, sir.
Can I move on with the history?
Go on with the history.
So she gave birth to her girl baby at identical GH. Since she had increased agitation and baby refusal, she was referred to Madurai GH, where she was evaluated with CT and MRI brain, which was normal. And in family was not interested in further evaluation, and hence self-discharged and brought her to home. So after getting this history, what are going through your mind, and what could be the reason they were not interested in further evaluation? What could be the reason?
The parents don't want to like mention it as a mental disorder. That can be one reason to bring the patient, lady, back to home, and the society will be knowing about the any condition that the lady is having. No.
Yeah, one chance. Yeah, what Amrut told is one chance.
Other chance can
And
be they are
at
from a
this
tribal.
juncture,
Okay,
yes,
you
sir,
can
at
go
this
on.
juncture, a role of CT or MRI brain is unlikely to order actually, unnecessarily exposing her with high radiation. So, because nowhere an indication like any neurological symptoms to suspect in her.
No, there weren't any neurological symptoms other than the fact that she was having thought delusions, saying that others were talking about. She was getting. She completely neglected the baby. Didn't want to feed the baby at all, and she was. Her communicative ability was also impaired in that she stopped talking or responding to anyone. When someone does that, you have to. I think one of the key things about this case is that when a postpartum mother develops such a rapid onset of altered behavior at 5 days, then one of the key things always is it a psychosis or a mental health disorder, or is it a physical condition like an infection causing a delirium? And it will be very important to separate the two out, because obviously the management is going to be very difficult. So maybe some of you could point out situations where you would think more of a physical cause rather than a psychiatric disorder. And what would suggest it's a psychiatric and not a physical disorder? Are there any, you haven't had the benefit of the physical findings. Do you like to just mention that before we discuss this point, Dr. Chitin?
Physical condition.
Vital signs.
Oh. On examination, she was having a stiff posture, emotionless face, vitals were normal. Systemic examination was also within the normal limit. Except she had some tachycardia.
But she was also quite dehydrated, wasn't
Yeah,
she? So
yes, sir.
when we saw her, she was very, very dehydrated, not responding to any attempt at communicating with her. The parents were saying that she hadn't slept at all for 3 or 4 days. She was just sitting there staring and talking to her and saying odd words to herself. So there was no temperature. Dr. Jithan said there was a tachycardia of about 110. The blood pressure was normal. Her respiratory rate and saturations were normal. So what features in this case would point to a psychiatric as opposed to a physical problem? And what kind of physical problems would you be thinking of at this stage?
Sir, what actually stiff posture means, sir, here in this patient?
She was not, whenever something was put in her mouth, she was just holding it in her mouth. She was not moving her arms or limbs, and she was just sitting there and looking at one position on the wall.
Okay, so.
Sorry, I missed some history. Here, we did one home visit there. She was found talking to herself. She was not having any motherly affection towards baby. She was holding food and water in her mouth for a long time. She had decreased sleep. She used to cry sometimes. Her body was stiff.
Okay, so you got more history now that Dr. Jithan has given you. What features would suggest a delirium, that is a physical illness causing altered behavior in this patient?
The stiff posture can be one.
All right, the stiff posture may point to something. It could be a feature of psychosis where people get into a catatonic state. So that's one. But what are the, let's look at, not just in this case, but in general, what would, when would you think of a physical condition like meningitis presenting like this? What are the physical conditions that could be occurring in this woman that would cause altered behavior? Let's look at the conditions that could be affecting her.
Cortical vein thrombosis.
Right, yes, cortical vein thrombosis is a very serious postpartum complication. So I would think that in Madurai they were worried about that. That's why they did the imaging. And I agree that CT is a high radiation thing. And ideally for that, you need an MRI venogram or a CT venogram to do that. But what would suggest cortical vein thrombosis in a patient?
Dehydration.
Dehydration may lead to cortical vein thrombosis. That's one of the precipitating factors, and the hypercoagulability after pregnancy. Generally, they will have headache. The main thing about them is that what will their conscious level be?
Will be.
Sir, if we suspect CVTC, sir, most of the times they present with headache, vomiting. I mean, mostly with raised ICP symptoms, no, sir, like headache, vomiting, altered sensorum will be there rather than the altered behavior as we are encountering in this patient now.
Right. So one of the important differences between a delirium and a mental health disorder is the alteration in conscious level and confusion, isn't it? Disorientation in space and time is a feature that suggests a physical illness. Generally, people with a mental health disorder, if you can get them to communicate, are not disorientated or confused. So that's one factor. What about the speed of onset differentiating between delirium and a mental health disorder?
Delirium really is an acute event, no, sir.
Correct. It's usually quite rapid, isn't it? In this patient, it's quite rapid, but postpartum psychosis can be quite rapid in the initial period. It can occur after 5-6 days as well. But generally, if someone develops an altered behavior very quickly, you'd think more of a underlying physical condition. Anything else that would suggest a physical problem rather than a psychiatric problem? What about the vital signs? What will, in a mental health disorder, you would probably get some degree of tachycardia. You may get some dehydration because of the lack of care for themselves. But you won't get a fever, will you? Or change in respiratory rate to this degree, or hypoxia,
Yes,
which may suggest a pneumonia. And what
yes,
kind of
like,
hallucinations will people with delirium get? Do they get auditory hallucinations?
yes, sir.
Auditory.
Yeah,
And,
no,
visual.
people with delirium due to meningitis
Visual
or
hallucinations.
drug
Visual
abuse.
hallucinations.
Yeah, right. They'll get visual hallucinations. So the auditory hallucination is unlikely in a delirium. That usually suggests a mental health disorder.
Schizophrenic patients.
Yeah, and in her case, that was a family history. So remember, when you have a person with such a rapid onset of altered behavior, is it delirium? Is it a mental health disorder? So looking for the rapidity of onset, looking for confusion and disorientation, that's very important. Looking at the vital signs and looking for what kind of hallucinations they're having will help to differentiate. In this case, it suggested strongly that she had a postpartum psychosis. Patient's family were not willing to have treatment, and they were at home, and we were informed by other village people that she was sick and unwell at home. So when we saw her, she was quite dehydrated with a slight tachycardia and in an almost catatonic state. So is this a medical emergency?
It is a medical emergency
Yes,
because
sir.
the baby's
Yes.
life is in danger. She may not be feeding properly.
And could they harm the baby?
Yes.
They can.
Yes, they could positively harm the baby, isn't it? So it's a medical emergency in two senses. One is the baby's life's at risk, and the mother's life's at risk because she was going to get increasingly dehydrated and all the complications that follow that. So ideally, what should a family physician do?
Should refer to psychiatrist if possible after starting the medication.
Right, I think it's she certainly needs to be in a hospital, doesn't she? It's difficult to manage her as a family physician, particularly when she's not drinking, she's holding things in her mouth, and she hasn't slept for 3 days. That means she's in quite a severe state. But so this case illustrates a few points. One is a differential diagnosis between psychiatric and physical illnesses that occur postpartum. And the other is the role of a family physician. According to the books, she needs to be referred immediately. But the contextual factors that often influence the decisions you make are that the family refused bluntly to go anywhere. So then you have to engage the family as to why. Why do you think they were refusing, which is the question Dr. Jitin asked.
It is a social stigma in a village, especially in villages, sir. Like they were being occupied by the black magics, or if it is known to the neighbors, and then they may avoid socially in the village, in a remote village such like that. That might be the fear of her relatives to take her away from the hospital, so that is what I think.
You're right. In engaging them, you've got to look at it in an empathetic way. There are beliefs about that. Their main belief was that this is an evil spirit or some kind of devil possession, depending on what kind of faith and background you come from. In this situation, how would you approach that, dealing with that? Because this lady is her life and her baby's life are at risk. So should you look down on those beliefs? How would you engage that?
Uh,
We can have a meeting along with the family members, along with the uh, other relatives to counsel them about the condition and the need for in a center, necessity to admit the lady in the center and give a good treatment.
Okay, you could do that. I think, what are you going to do about their beliefs? Are you going to confront them or are you going to roll with them?
It's better to
No,
roll
that's
with them, and along
rolling
with
with
we may
people.
give an advice, like we'll roll with them and we advise, like we may give an advice them better follow your beliefs also, and along with that go by the treatment of a doctor, a physician, a well-known psychiatrist also will help us like that. I think it will give us a better result, sir, rather than
Yes.
Okay.
simply refusing them.
That's right. I think you need to roll with them. Never try to confront that or criticize the person's belief. What we said was, we understand that in your belief, this is due to some kind of possession or evil spirit. But in our way of dealing with this, there are other ways we can also help. So first, acknowledging their belief and not necessarily criticizing that, that's old-fashioned, it's not scientific, it's stupid. That kind of confrontation will not help. So we said that we understand what they believe, but in our way of dealing with it, this is what the issue is, and we can help in other ways as well. So that's one thing. And the other is in this case, we had a good relationship with this family because the brother who had schizophrenia, he had responded to treatment, he was doing well. So always a family physician has a great advantage in that, rather than referring to a hospital where people will be unfamiliar, they won't know how to communicate as well. So, textbook-wise, we should be dealing with this, but the contextual-wise, we have no choice. So this is a case illustrates why you should know the best, but also know how to have an extended role in conditions like this. So what could you do to get a mental health opinion on what to do for this lady? Would you like to have a specialist psychiatrist input here?
Yeah, we can take the help of a psychiatrist. If
But they
patient
won't
does
go
not,
to see a psychiatrist.
She's not good.
then we should treat.
Right? But can you get a specialist psychiatric input?
We can call them and
Uh,
ask.
yes,
And you certainly
Situations
can, isn't it?
we can
Nowadays, it's quite much easier
discuss.
than in the past to go and call someone and ask. And nowadays, with what the technology you're using, you could even have a video consult. But I think in such a situation, the psychiatrist is also going to find it difficult, and they're going to find because she wouldn't have talked at all. She was just staring at the face, at the wall, and not responding to anything. So I think the first thing was to acknowledge that. The next thing was to get them into a place where we could correct a dehydration, start protecting the baby, making sure the baby was being fed properly. And that's the second thing. The third thing was to get a specialist mental health input. So she was discussed with Dr. Soni in CFH. And we started, who felt she did have a catatonic state. And she was started on risperidone and diazepam as well, which is what he advised. Why is risperidone good in this condition? Why not olanzapine? She wasn't sleeping.
olanzapine will have another side effects of any like hyperglycemia, dyslipidemia could be there now. So.
And hyperprolactinemia which can reduce the secretion of the.
Yes, sir.
Okay, so the advantage of risperidone is that it's quite safe to breastfeed, and it in fact enhances breastfeeding because by causing hyperprolactinemia, it will encourage milk secretion as well. So, one of the side effects of risperidone is that you do get galactorrhea in treating people.
Galactorrhea.
Yeah,
Olanzapine would be a good choice in schizophrenia where people are not sleeping. In the long term, I agree, it does increase diet, it causes a metabolic syndrome and predisposes to diabetes. But its effect on sleep is often an advantage, but not here, because it's not really safe in a person who's or at least has a chance of getting back to breastfeeding. The way she presented, she wasn't breastfeeding at all. So would you like to comment on what the progress was, Dr. Jitin?
Initially, she was in catatonic phase, so and dehydrated. So our priority was to hydrate well. Hydrated, and baby was separately started on formula feeds, and we in 2-3 days stiffness get rid of. She was initially was staring, and she started replying to our talk slowly. Now we latest she was discharged, and she had some fear afterwards also, but she's improving very much. Like she walks. One thing one part of treatment was like we advise her husband's love is important. Usually they used to believe some demon possession and all in the society usually. So we told that love and affection given by the family members is one of the most important part of treatment, and I saw that it was one of the important part of treatment, understanding them along with medication, and she's improving well.
Okay, thanks for that. So she actually, initially it was very difficult to feed her. She wouldn't take food, she would keep it in her mouth, and it will take 1 hour to get fluid. So a nasogastric tube was inserted, and fluids were given that way. And eventually after 3 days, the nasogastric tube could be removed. So she was responding. The content of her thoughts, however, became rather depressed, that she was a useless person, she was not a good mother, and she started expressing feelings of guilt. So as often in mental health conditions, you get conditions like schizophrenia or psychosis mixing with depression and anxiety. So she was also started on fluoxetine. But I think her improvement was due to the risperidone, which acts a little faster. And I think Dr. Jitin made a very important point, because the treatment of postpartum psychosis or depression includes medication, but also encouraging some aspects of cognitive behavior therapy. It's not your fault. It's not your fault that you feel like this. People do get unwell, and there are others like you. So making the mother feel not guilty is crucial. That you are a good mother, you can be a good mother. Okay, it's okay that people do get this kind of symptoms sometimes after childbirth. And so making her feel that she can cope, that was crucial. The other was, as Dr. Jitin said, was to engage the family. Because after childbirth, the expectations of a family on a mother are enormous, especially in Indian culture. I think so those of you like Dr. Albin who have had a baby will know what to feel, that what you expect. Oh, it's a happy occasion, you got to smile, you got to feed the baby straight away. But when a mother gives birth, there are not catastrophic, but massive changes in her body, and she needs rest, and it's okay to feel tired. So some mothers do go into baby blues, and when they and if it goes more severe, they go into a depression as well. So getting people to understand that it's no use saying you're a useless mother, because your expectations of joy and happiness are different to what's actually happening. So it's crucial to engage the family, and this is where family medicine has an advantage over specialists because you know the family, they're going to listen to you, especially you've had a relationship in the past with these patients. So ideally, she should have been in a hospital, but we had no choice here. And the contextual and individual factors that you understood help you to provide essential care that resolved a dangerous situation. I don't know whether you have any questions on that one.
Okay, sir. Keeping apart from the psychiatry, like psychiatry issues in her, what might does the hypocalcemia a reason for stiff posture kind of thing? So can we consider as hypocalcemia also? Because chronically she is not eating well for the 3-4 days and all, and also a postpartum lady.
Right, so hypocalcemia is an uncommon problem. It will generally present with tetany and muscle weakness situations. I don't think this will be a characteristic presentation of hypocalcemia. I think what we did was we did a hemogram, we looked at electrolytes. It was important to rule out physical cause, so we did an ESR.
Yes.
And we did a thyroid function test as well. We already had the benefit of imaging, which had been done at Madurai, though I don't think that was indicated in this case.
Yeah.
So I think there wasn't very much differential diagnosis here. So once you made a clear diagnosis, it's important to carry on with those aspects of treatment, engaging the family, encouraging the mother, and starting medications. Now, how many people after delivery get depression or psychosis is rare, but postpartum depression is very common. After birth, childbirth, in Western studies, how many percentage get postpartum depression, not just blues?
46%.
That's a good figure. It's, some people say up to 10% of mothers get it. Now that you could question that because in the Western countries, there are different cultures, different expectations, and different levels of help and management available. So they will probably diagnose even mild cases as postpartum depression. So I would think about 6 to 7% do get postpartum depression. So how can you screen for this? Because it's a condition that causes a lot of unhappiness. If it doesn't get treated, how long can depression last in postpartum mothers?
May long up to even she may continue to the depression also.
Go on for months, isn't it? She may not completely neglect the baby or herself to the degree this mother was, to the severity this mother had. But it'll cause a great deal of unhappiness, isn't it, when it's not treated? So in Western countries, they generally screen for postpartum depression in all mothers. And in general practitioners, family physicians are encouraged to screen mothers at the first antenatal check that they have. So what kind of phase of screening do you have?
Postpartum depression scale.
Postpartum Edinburgh.
So Dr. Jitin, would you like to talk about the EPDS or Edinburgh Postpartum Depression Scale?
It's a screening test, sir. Which include, sir, actually I was supposed to add that thing.
Okay, that's okay. That's the APDS is a well-validated test. It tries to score. It's a screening test, and it just asks some very simple questions. How do you feel you're coping with your baby? Straightforward questions, and it's got a scoring system. And if you get more than 10 points, it suggests that postpartum depression is likely. So family physicians are encouraged to use that tool in the first postnatal visit. However, there are others who feel that the depression, the postpartum state is no different to depression in other people. That is, those who have not had a baby. So they feel that the 2 screening questions for depression that you ask anybody else is enough, and you don't need to do the EPDS. I think the EPDS is a good tool because it's direct questions to the situation that a mother's facing postpartum about how she's handling the baby, how she feels supported or not, and all that. But the 2 screening questions you ask anyone in depression are what?
Sir, book says like most of the ladies in first 3 days will feel like depressed. Is it so, sir? Anything like that? And after 3 days, slowly they regain their or they
That's correct. That's called the
will work.
postpartum blues.
Blues.
That's not postpartum depression. Generally, the postpartum blues are not so severe. The woman might feel anxious, she might feel excessively tired, she might feel tearful, and she might question her adequacy in caring for the baby, but she'll still care for the baby. When a mother gets to a state where she doesn't care, then that becomes a mental illness.
Yes, sir.
So the postpartum blues and depression are similar. Depression is important to diagnose because if you don't diagnose it, the baby may not be at risk, but it can last a long time and destroy happiness in the family and cause marital discord and everything. So it's important to diagnose it. The EPDS is a good tool, but generally what 2 questions can help you other than the EPDS?
Are you feeling happy with the previous things that you have
Loss of
are you
trouble.
happy with the previous? Yeah, and
Mood.
and mood and allodynia.
Right, so
Unhedonia.
that's right. So dysthymia about not enjoying things that you previously enjoyed, and a low mood. Is your mood low or down? So if the answer to those is negative, then you're not likely to have depression. However, I would encourage you to look at the Edinburgh Postpartum Depression Scale because I think it's quite specific to as I said, to the postpartum state. And so it's a very useful tool for family physicians to have.
I'll be sharing that postpartum Edinburgh in our group, and difference between baby blues and postpartum depression. I will be sharing in the group today.
Sir, if it is like postpartum depression, sir, which drug we can start her on, sir? Like SSRIs or any like mood stabilizers are needed.
SSRIs are the safest drugs. But before I say that, I think it's in mild cases of depression, mild to moderate cases may respond to help, as I said, giving the mother encouragement and saying that it's not her fault, it's nothing to feel guilty about. People do feel this way. There are others like her who feel this way. It's not something to be ashamed about. And secondly, helping the parents, both husband and the in-laws, to understand what she is going through, that it's not her fault and they need to be supportive. That itself may be enough in mild to moderate cases. Those who have more severe cases where they're neglecting the baby and not caring, then you need to have an SSRI. Most people recommend sertraline, but fluoxetine is safe. It does take, like all SSRIs, it'll take 2 to 3 weeks to work. But sertraline is a drug of choice. I think it's more because of the absence in breast milk. But fluoxetine we've used that. I've used that a lot of times, and it's not. I don't find that a problem.
Sir, how to convince the relatives, sir, especially when she's having depression rather than psychosis? Psychosis, she will be socially withdrawn and all negative symptoms will be more. But in a depression, like she won't be having more negative symptoms and all, she will be doing well with the surroundings and all. Then how can we convince them that she is having some disorder with her?
Yeah, generally in depression, the negative symptoms are strong, and she may not be showing enjoyment. She may feel she's a bad mother. She's feeling guilty, all those things. And there, whereas the expectations of the in-laws, as I said, is completely the other way around. So you need to explain that some mothers do develop this and it's not their fault. Generally, when you say that, it's something totally different. It catches them initially off guard, but they begin to understand that. And that if you want to help the mother to get better, there are maybe medications needed, but their input is crucial. Give her adequate rest. Give her the support she needs. Give her the encouragement that it's not her fault. They themselves need to say that. Help her with the chores. Make sure that in between breastfeeding, she gets adequate sleep. When you say that, it is difficult. It is difficult for, especially Indian culture, to accept that. But especially as a family physician, you have a relationship with these families. You might have seen them in the antenatal period. You're following them up in the postnatal period. You might have known the family for other reasons, like we knew this family. You got a good, your statements like that are important. It's not important not to go with just drugs alone. If you do that, you're not going to win. So, good to
Yes,
have
sir.
Dr. Sony's input in this. But anyway, I hope this case shows that how important mental illness is in family medicine. I think 1 in 7 to 1 in 10 of
The
our
chance
cases.
of becoming her again, like being like getting psychosis in another, I mean, next pregnancy, sir, like.
There are risks, but you can be more prepared. You can ask the parents to be more prepared. There may be people who need earlier treatment as well before they get to recognizing early phases of psychosis in the late antenatal period. So that there is a risk of this, yes. But if the family are more supportive, there may be less of a chance of a relapse. Shall we go on to the next case? So there are a few things that are common between this case and the next case in a broader sense, so we can talk about that.
You can.
Thank you.
Yeah, actually, Jibin just enable the screen share. I cannot share the screen.
Can you share now?
Just 1 second.
In this case, are her relatives accepted that she is having some disorder, psychological or psychiatry issues? Are they coping with
yes.
her?
They're being very supportive. They were initially scolding her and calling her names and things, but as time went on, they began to be very supportive, particularly her husband and mother.
Good to know, sir.
Are you able to do the EPDS score for postpartum patients in Kesapatiza?
No, we are not, because we haven't been doing that as a routine. Because most people nowadays, as you know, the government is doing most of the vaccination. That's the time when we see the mothers. But it's something that you can consider, especially in the postpartum period. I start screening them. I think in family medicine, it's a good tool. And we should be in a position to use it more often in India. It may be a part of your team, the nurses or the health workers who can administer that.
You were doing the HID scale by the health workers there were doing the HID scale. Are they continuing that?
They're continuing it some of the time. Yeah. When we ask them, they do. Occasionally they will, when they think it's a mental health problem, they do it before the doctor sees them.
Thank you.
Fala, we can see the screen now.
Yeah,
Yeah.
okay. Can you start, sir?
Yes, sir.
Yeah, we can start.
Yeah.
Yeah.
Yeah, okay. This is a story about a lady who hesitated to meet our health day. She's 20-year-old Kalishari. She was staying with her husband and one child of 1.5-year-old, and her husband's brother and his family in Kulavikare. Kulavikare is about some kilometer from away from a follow-up area, so he was not under our follow-up list. Now she came to Siruvatikada for past 1 month as her mother's home was there. We accidentally saw this lady while we were returning after seeing our follow-up patients. We got a call that one unwell lady is not willing to see you, sir. She's over there. And some lady called us. We went there home. She was having, she was complaining of chronic cough with mild sputum and tiredness for past 20 days. There was history of cold for past 2 weeks. There was history of loss of appetite. She was taking very less food only. No history of that much loss of weight they noticed. No fever they were telling. No chest pain on taking breathing. No history of any vomiting. No altered bowel habits or blood habits. On examination, she was looking drowsy. There was pallor. No puddle edema was there. On examination, a hair entry bilateral equal we heard, but there was bronchial breath sounds heard at the left interscapular and infrascapular areas. Other system examinations were normal. What do you think at this stage? Can you give any suggestions or DDs? Something like
Pulmonary tuberculosis.
Pulmonary tuberculosis is a probable DD. Then anything other than that?
Can be any retroviral disease.
Retroviral disease chances.
Retroviral HIV. That's what Jithan is saying.
Yeah, that's right.
Okay. Where is the other? Anything other than that? I mean, a short history, plus acute subacute history of 2 weeks or 3 weeks history. Or actually, we got history of 1 week history. On digging up the history only, we got it is after coming from Kuloikare to Siruvatikad only she got. Then we calculated. Last visit we visited 35 days back. After that only she came. After that she got something like that. So
Can you go to the previous slide here?
So
Previous slide. Previous slide.
Previous slide.
Why is she drowsy?
She was tired only, sir.
Conscious
She
oriented.
was sleeping.
Yeah, she was GCS was 15. She was looking tired. I think the drowsy was not quite right. But I think there are a few things I like to talk about in this lady's what she illustrates. Obviously, tuberculosis, and anyone with cough and fever more than 2 weeks has got tuberculosis until proved otherwise. And I think that the WHO is increasingly stressing the importance of presumptive diagnosis of tuberculosis. So the other aspect is it pneumonia? Could it be pneumonia?
Yeah.
No. So pneumonia, 80% of people get over their pneumonias on themselves, on their own. 10% will die, either in the acute stage or later on. And another 10% will be left with severely bronchiectatic lungs for the rest of their lives. So there's one other thing that you'll be worried about if she got breathless, isn't it? That's nowadays in the contemporary problem is coronavirus as well. That could be an issue here. But that's going on. If it's going beyond 2 weeks, then that's unlikely. But the way she presented was between 7 to 14 days. So in this patient, she was a tribal lady who lived in a village between Kulavikara and Siruvatakara. Kulavikara we do cover, but she lived in a hamlet between the two villages, so it was quite isolated. She's a traditional Adivasi girl who gets, is still one of the many Adivasi families who do not have exposure to outside contacts. And she was scared. She refused to come out of the house and see us. Only others informed us that she was ill and we need to see her. So you're dealing with this situation. What would you like to do? She wasn't willing to come to her hospital straight away.
Health worker. You need to use the health workers.
Okay, that's a good point. The health workers may have more rapport with than we have, especially if the staff are from that community. She was still not willing to come.
You're suspecting tuberculosis, take a sputum sample and send it down for testing.
Right, that's good because we can't do an X-ray here in the middle of a forest because that's where Siruvatakara is. It's a village surrounded by reserve forest. And it's 6 kilometers from the road, and she's bluntly refusing. Then you can take a sputum AFP, isn't it? In the village itself. That's not a difficult thing to do. What's the more urgent treatment she needs?
We can ask for the family support if they are willing. What are her fears we need to address first?
Nutrition.
Yeah, she was scared to, basically she's scared to come to any contact with outside help. There are a few tribal people are still like that. But from a differential diagnosis, what condition it can be rapidly fatal? Tuberculosis is a slower course,
Pneumonia.
isn't it?
Pneumonia.
Yeah, pneumonia, isn't
Pneumonia.
it? So could we treat that?
Yes,
We can treat that.
And start an antibiotics.
Yeah, what treatment would you give her?
Amoxicillin.
You can start with amoxicillin. If you want to get the first dose in properly, you can start with procaine penicillin. It covers Streptococcus pneumonia, which is the main causative agent of pneumonia. But you need to cover atypical organisms as well. Isn't it? So either we start doxycycline or you can use azithromycin. I usually prefer azithromycin in situations because it's got a very long half-life. And once you give a loading dose, so it can go up to 30 milligrams per kilogram of a loading dose. It will last for at least a few days. So, and it will help in the management of pneumonia, even if it was due to strep pneumonia. So either doxycycline or azithromycin would do it. That's what she was started on, and a sputum AFP was taken. So what would Dr. Fella like to continue on with this patient?
One more thing, sir. Many a time these sputum AFP, pulmonary tuberculosis patients have associated diabetes also. It will be good to do a GRBs also.
Yeah, I think a blood sugar was done and it was normal. Anemia was all. We are usually generally aggressive about treatment of anemia as well. So in that case, parenteral iron taking a risk giving it in a peripheral village, but it's really crucial to treat the anemia as well. Giving her oral iron is fine. It'll cause rise in HP at the same rate as parenteral iron, but adding it to other drugs like amoxicillin and azithromycin, where there are drug interactions and absorption of these antibiotics may be impaired by iron, and in a person who's not very cooperative, then I would give parenteral iron. Dr. Fellas, I'd like to say what happened.
Yeah, actually, here apart from clinical details, individual factors and contextual factors are means a lot. Here, the individual factors, she was not ready to meet our health team. As she was having the above mentioned symptoms, actually earlier she was taken to a park in Pachalur 1 week back and spent about 1,000 rupees for taking her in one taxi and for treating there. Actually, she was given vitamins, supplements and cough syrup there. She and her family were thinking that that symptom will be cured by this. That's why they are not ready to meet us. That those are the main individual factors we met there. The contextual factors, she stays as in a hamlet between Kulavikara and Siruvatikada, which was not under our follow-up list. Now she came to Siruvatikada, where we can follow. Her mother was an old pulmonary TB patient who took 6 months ATT about 5 years back. Her husband's brother, we told about her family, where she stays. Her husband's brother diagnosed to have TB with pleural effusion 1 year back. For him, ATT not completed taken. And the patient, her husband, and her parents are illiterate. She is staying in a thatched home with no windows. 6 people were staying there. That is also one contextual factor. Already spent 1,000 rupees and not willing for spend more. And she is having a 1.5-year-old child. And because of lockdown, if she advised to go there, go down or take some X-ray or something, she cannot go. This much contextual factors are included here. So we near with the clinical details, we cannot treat at all. So the individual factors and contextual factors, see how much important in treating a patient. Yes, sometimes it is more important than clinical details. I am agreeing clinical details are important, but as much as important, individual and contextual factors matters. With all these, it sum up the patient's data. Actually, patient was seen by our team in Siruvatikade. From there, we took HB. It was in 7.5. Spot sample of sputum may have been taken. As bronchial pneumonia was a differential diagnosis. We treated with penicillin and given amoxicillin and tabacitro. And patient, the sample we took and we came down and done. And on that day, it came as sputum FVQ. We informed the government ANM. We informed the patient also. And we already we called the patient to KC Patti surrender the next day. Patient came. Patient was not willing for taking ATT from GH. From the 2 more samples of sputum taken, which also showed few samples. Chest X-ray, ICTC, CBNet, all are advised, but patient cannot go down. We started ATT with an alternate day regime. We kept the patient in KC Patti for 3 days. That is on from Monday to Wednesday. On 3 days, we got 2 days of ATT days. ATT treatment with alternate regimen started, and patient was reluctant to take the drugs. So we mixed the drugs with the sugars and made to take. We checked whether patient is compliant or not. And as she was having anemia, 2 doses of interferon, MFI, albendazole, vitamin B12 injection already given, and patient sent back to Sirvatikada with 4 weeks of medication. Sister Rani is looking after Sirvatikada village. We informed her, and she is supervising the medications of patient. So these all are the steps. Patient seen by our team. Patient taken to a comfortable center where patient also comfortable, and as patient cannot go down, we with our even with our limitations, we ensured patient is getting good treatment. The even though it is not ideal, we 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 applied what the ideal treatment in a limited center, and we ensured the patient is getting that, and we checked whether patient is getting apart from writing or prescribing a medication, we ensure whether patient is taking it or not. After that, we send the patient back to home. After that, also the follow-up, the important part of primary care, we are sticking on that. We are taking measures for following up also. That is the story of a lady who hesitated to meet our health team, and who were supposed to meet because she was the ideal candidate to get an ideal treatment. That's it. Back to sir.
Thank you very much for presenting, Dr.
Thank you.
Fala. I think just want to illustrate this patient. There are a few points that come up. What do you feel about treating a person who has pulmonary tuberculosis without a chest X-ray?
With the RNTCP two sputum HB positive is okay to start ATT.
Yeah, I think
Microbiological diagnosis is more important.
yeah, the microbiological diagnosis is always confirmatory, but can you get false positive sputum AFBs?
Can.
You can, isn't it? There is even in the best labs, there is a significant incidence of false positive due to other mycobacteria as well. So in the past, the WHO had clear criteria, which in the more recent guidelines are blurred, where you would say that one sputum AFB is not adequate on its own without a chest X-ray that suggests it. So always guidelines are good to follow and know about them, but they're not always the ideal when you have contextual situations like this, which are overwhelming factors when you take it into consult with the clinical factor. We did get more sputums in the end, and they were also positive, so that confirms tuberculosis. But sometimes you're not going to get a chest X-ray, though it's ideal. The current WHO guidelines do recommend a chest X-ray because those sitting in Geneva don't understand that some people won't come and have an X-ray, and you need to diagnose them at home. But you need to know that it's not the ideal thing to do, to start a person without a chest X-ray, because though the sputum is confirmatory, an X-ray nowadays is considered almost mandatory, isn't it? So the other aspects of this patient is that her children, I'm not sure whether Dr. Fala mentioned that she has a child who's aged 2 years. What would you do about this child?
As that child is exposed to her, and it is a lot of contextual factors are there for enhancing the risk as it is a overcrowding home, and there is two TB patients. One is her and one is that child's uncle. So child is supposed to start
Okay, what's the WHO say about children who are contacts of tuberculosis, sputum positive patients?
Prophylaxis with INH. They should be screened initially for. They should be tested whether they have active tuberculosis, and if it is not there, they should be given prophylaxis with INH 5 milligram per.
Now, this is a critical thing that Dr. Albin is saying, because the WHO has, in fact, stressed this and published guidelines this year itself, showing the fact that they want to be more aggressive about detecting latent TB infection and managing it more aggressively. This is a very important development, because for staring us in the face for the last 30 years, that in trying to control tuberculosis while waiting for patients to present with active TB and treating them aggressively is nonsense. Because by the time they come present, like this lady, they present late and they have spread the TB to 20 others. So where are you going to get control by just treating the active cases properly? Of course, that needs to be done. But more important is the stress on detecting latent TB infection, because many people are infected with TB, and 10% of those who are infected will develop active tuberculosis in their lifetime. So unless we treat this more aggressively, we are not going to control TB. And the WHO has produced guidelines this year which show the role of primary care practitioners in chasing up those who have sputum positive tuberculosis. And I'd invite you to have a look at that. It's a long document. You just Google prevention of tuberculosis and WHO guidelines 2020, you'll see that. And it's really crucial that this is taken up as a priority. The children have to be managed. And as Dr. Albin said, we have to exclude active tuberculosis. How are you going to do that?
For children, this case is it's a 1.5-year-old child. So ideally, sputum need to be taken, but for this child, we can take gastric aspirate and send for AFB.
Right.
Or
easy thing to do.
Chest X-ray we can do.
Yes, a chest X-ray might help you, but there's some people are cynical about chest X-ray diagnosis of TB in children. But if it's obvious, what about gastric aspirate?
Gastric aspirate, AFB, we can do, so that is.
Okay, the gastric aspirate, just to, because to reduce the time, is a very sensitive test, and then you do a CB NAT on it, or a gene expert test. But a smear itself is not very sensitive, a gastric aspirate smear, but it will help. But what are the other ways of considering active tuberculosis?
Loss of weight. I mean, weight get.
Failure to thrive. A child who's failure to thrive, who's a contact of someone with tuberculosis. Any child under the age of 5, which is what the WHO says now, who's a contact of person with tuberculosis, who's having failure to thrive, has got active tuberculosis. That itself is enough. Or a history of fever and cough, isn't it? So those who have fever and cough, who have failure to thrive, those who have abnormal chest X-rays, those who have smear positive by induced sputum or gastric aspirate, have active tuberculosis. They need to be treated with full TB treatment according to the protocols. But what about those who don't have those symptoms?
How to treat?
Okay, the preventive treatment's been updated, and it used to be just INH for 6 months, and that's still an option. But you can, if you look at the WHO protocols, they advocate once weekly rifampicin and INAH for I think it's just 1 month actually. And the other option is rifampicin and INH for 3 months.
Yes.
That's another option now, or rifampicin alone, I think, for 4 months. You need to look it up because this is the primary physicians, the family physician's role in this is going to be critical because the thrust is finally, after 30 or 50 years of staring us in the face, the WHO has published this thing about the prevention of tuberculosis by managing those with latent TB infection aggressively. And therefore, family physicians will be at the forefront of this. So this child, what would you do? We haven't got previous weights because they were in a hamlet which we weren't covering, and we only got a spot weight.
Spot failure to thrive indicator is mid-arm circumference or weight by height ratio.
Okay, these showed the child has malnutrition, grade 3 malnutrition. What would you do?
We have to start active ATT treatment because
I wouldn't give this child prophylactic treatment. I would be aggressive. I would give full treatment because unless we do this now, we are not going to prevent adult tuberculosis later. And the current guidelines of pediatricians will be that you must do a MON2 test, you must do a chest X-ray, and you must try and gastric aspirates or smear if you can to rule out active tuberculosis. Here, the overwhelming contextual factors, you'll be foolish to say you could do all that. Meant that we'd be much safer giving full anti-TB treatment. Now, which is what we are doing for this baby. We are giving the full government protocol for active tuberculosis. Many people will criticize you for that. They say that you're over-treating, but they're living in a different world. So I'd like to present this patient in many sense. One is the challenge she faces in an isolated area. Has she got pneumonia? You had to treat it. We gave her a full course of penicillin, even with the sputum AFP. The second thing was treating the nutritional aspects, particularly anemia, and being aggressive about it. Sometimes having to use parenteral iron because you make sure they get it in. Thirdly, you have to deal with the family's own fears and feelings. I'm not going to go into that because that will take a long time. Next, what about the contacts of this patient? You've got to be more aggressive than you were. Can't just sit in the clinic and start people on anti-TB treatment and not chase their contacts up. Of course, they all need HIV tests as well. But you need to be ready to apply the best guidelines to an individual's context and their individual factors. And that's, I think these last two cases show that as something that family physicians need to be proud about. We're not going to get accolades for doing this. We're not going to get any money for doing that either. We're not going to get any income by doing this kind of thing. But if you want, as Christians or whatever, as ethical doctors, you want to have a system that practices social justice and equity, you can't do it sitting in the hospital because these two patients would have either died or got into a very unhappy outcome without primary health care. You cannot say we'll practice fair medicine and social justice and equity by sitting in a hospital. As only family medicine is essential to do that. So I hope that in these two cases I did that. We chose to present it as an example of that, and hope you will be proud to be family physicians, even though most of your training will have to be in a hospital, because that's where the clinical science and features will present. Always look at the family medicine aspect. Go to your peripheral clinics, get involved in that. And always don't be scared if your guidelines don't fit what you're doing, because you feel you're doing the best, taking into account what the patients will be willing to do. Okay, I think I've talked too much there. Anything else you wanted to discuss about this?
I really appreciate Pala's presentation, especially the individual contextual. A lot of issues brought up under the individual and contextual, and also the way he presented how she moved from Srivatika to Kesipati to GH to again back to Kesipati. That presentation is very good. Thank you. And thank you, sir, for placing both the cases in
Thanks.
context.
Thank you, sir.
Okay, please do look at the WHO's prevention of TB guidelines, which have just been published, because your role is crucial in that.
Any questions?
Thank you very much to Dr. Jitin for hosting this. The first
Yes,
time
yes.
I've been involved in something like this. I think it's a big effort and
Yes.
must have been some anxious moments getting things to work. But thank you very much.
Thank you, sir, for sharing your time with us and enlightening us. And family medicine, we are proud to be a family physician, sir.
You're not going to get any money by doing it, and you're going to have to make some sacrifices. But if you care about social justice and equity, don't expect an income. If that makes you happy, then that's what you should follow.
Thank you, sir.
Thank you very
Thank
much.
you. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
We just want to welcome Karthika and Saranya, our fresh first year DNB residents who have joined and who are presenting in the group right now. Dr. Karthika and Dr. Saranya, they have joined family medicine last week.
Okay.
Thank you, sir.
Thank you, sir.
Okay, shall we end the meeting then?
Yes.
Yeah.
Bye.
Thank you. Thank you. Thank you, everyone.
Good
Thank you,
night.
sir.
Good night.